Hi everybody, welcome back to Hormones and Health with Dr. Heike. So let's go on to treatment. How do we treat prolactin disorders? So the good news is that prolactin is very treatable and it's treatable with simple tablet. Main medications that respond really well to getting the prolactin levels down are dopamine agonists. And there's three main ones that we tend to use. Cabergoline, this is the most well tolerated with the least amount of side effects, so it's commonly used as the first line. Bromocriptine has been around for a long time and it also has evidence in pregnancy, therefore that's usually a second line option. And quinogalide. All dopamine agonists come with some side effects. This could be dizziness, headaches, but usually the doses are very low. We start low and titrate up as needed according to the blood prolactin levels. So in most cases, if there is evidence of a pituitary adenoma, as the prolactin levels come down, this shrinks down the pituitary adenoma and normalizes the prolactin levels. Needless to say, if this was related to different medications like antidepressants or antipsychotics, or particularly anti-sickness medications or blood pressure medications, there needs to be an evaluation of a risk-benefit as to whether these medicines can be changed or reduced or monitored. Otherwise, we'd want to ensure that we'd need to do what's best for that specific case. So let's talk about fertility and pregnancy planning in the case of hyperprolactin. As mentioned, hyperprolactin is very treatable and most women will go on to have a normal pregnancy. The goal would be, once we've diagnosed hyperprolactin and started treatment, we'd be aiming to normalize the prolactin levels. And once the prolactin levels are normal, we'd want to ensure that those remain stable. So in terms of advising for pregnancy, we'd also want to ensure that we've got a stable prolactin level consistently within the normal range. And if there is evidence of a pituitary adenoma, particularly if it's large, we'd want to see there's evidence of shrinking of that, and that you've had at least one regular menstrual cycle. So during pregnancy, if you have a positive pregnancy test, we would normally advise you stop all dopamine agonists and you stay off those throughout the pregnancy. And in terms of the monitoring during pregnancy, this would involve visual field testing. We don't tend to do MRI imaging as there is a natural physiological increase in the pituitary gland during pregnancy because the body is changing and it's working hard to grow the fetus. So you would need to have regular check-ins with your endocrinologist as well as your obstetrician. So let's talk about long-term management. In the context of someone who has a hyperprolactin but they're not seeking a pregnancy, we would just tend to evaluate and monitor the prolactin levels consistently, periodically, say every 3 months or every 6 months, depending on what the levels are looking like. If there's any new symptoms or we're concerned about a pituitary adenoma growth, then we'd want to repeat the MRI scan. If we started off particularly with an MRI scan showing a pituitary adenoma, we'd want to repeat that later on down the line to see if there's been any shrinkage or if it has disappeared. When we're using fairly high doses of dopamine agonists, we'd also want to organize an echocardiogram, which is just a scan of the heart to look at the valves to ensure there's no evidence of valve fibrosis, which is a super rare complication of dopamine agonists, and it doesn't tend to be seen in the context of prolactin disorders because we use such low doses, but it is something that is still recommended as part of the evaluation. And often we can always think about stopping treatment at some point. So in general, we would want to see the complete shrinkage of the pituitary adenoma if it was present to start with, and consistently normal prolactin levels for at least a period of 6 to 12 months without medication, and to ensure that no symptoms have returned. If this was the case, then we would probably look at the level of monitoring and evaluation, but we'd also obviously advise that if symptoms were to come back again, then we would obviously need to start the workup again. Generally, we tend to manage for about 5 years, and usually after 5 years have a conversation, if things have been stable, about coming off medication and seeing how things go. So that concludes the topic. So to summarize, if you are struggling with irregular cycles or problems with fertility, and you may have other symptoms like headaches or abnormal breast milk production like galacturia, definitely seek medical advice to get prolactin checked. With the right treatment, most women go on to have healthy, successful pregnancies. One last thing to mention is Although this is a YouTube video and I've spoken mostly about women in pregnancy and fertility, this is a condition that can also occur in men, and similar symptoms if men did develop such symptoms of as described above, particularly if they have problems with libido, low sex drive, low testosterone, headaches, and they're noticing the galactorrhea. Yes, men can get the abnormal breast milk production as well. Then also to get this checked out. If you found this video helpful, don't forget to like, subscribe, and share. Thanks for watching Hormones and Health. See you next time. Bye.